Hello, everyone. Hello, I hope everyone can hear me. So I would like to welcome everyone to the webinar today on Talking with Caregivers about Overuse, a guide for clinicians. Before we start, here are a couple housekeeping items. You can download the slide and resource materials from the handout pane. We encourage everyone to participate in the conversation by typing your question and comments in the chat box. And please note that you will be mute until the Q&A sessions. And if you wish to speak, please click on the hand button to raise your hand and you will be unmuted when it is time for questions. After the webinar, we will send you the recording of the webinar and we'll post the slides for download at PCPCC website. And last but not least, please take the post-webinar survey. Your feedback will be greatly appreciated. About PCPCC, PCPCC, or Patient-Centered Primary Care Collaborative, aims to advance an effective and efficient healthcare system built on a strong foundation of primary care and the patient-centered medical home. Our mission is to promote collaborative approaches to improve primary care. We also promote the shared principles of primary care, which represent all aspects of healthcare. We focus on the concept of patient-centered care through patient-family engagement and patient activation, which will help reach the goals of improved cost, quality, and experience outcome. Through the Transforming Clinical Practice Initiative, PCPCC Support and Alignment Network strive to improve patient and family, clinician, and community strategies for engagement. We are working with our key partners to provide valuable education programs and technical assistance tools to help practice meet their needs. To learn more about how we can help your practice, please visit pcpcc.org/TCPI. And now, I would like to turn to my colleague Kelly for today's discussion.
Thank you, Tanya. Could I have the next slide, please? So we're very excited to have you here today. I'm Kelly Rand. I'm the Program Officer for Choosing Wisely at the ABIMF Foundation. And we're excited to give you a talk about Choosing Wisely conversation with a caregiver, because having conversations about overuse, as we've done in some of our earlier webinars, is not always easy. And there are more dynamics that are added when you bring in a family member. So we're hoping to connect to the patient and family engagement metrics of supporting for patient and family voice, particularly in this one, the family speaking for the patient. And we'll also really be focusing on the idea of a shared decision conversation. So we're hoping to touch on how Choosing Wisely fits the TCPI family and engagement metrics. Next slide. Choosing Wisely can be used for all of the metrics, in addition to the conversations we're going to have today. There are many ways that you can do it, and I've offered this slide to help you crosswalk if you're doing Choosing Wisely activities, how you can use those to satisfy your PFE metrics and some activities that are examples. I thank Main Quality Accounts who created the slide, and we'll move on to the main webinar for today. So next slide. Great, so we're very excited today to have Dr. Cate McKegney, a family physician in Edina, Minnesota. She received her medical degree from the Robert Larner MD College of Medicine at the University of Vermont and has been in practice for more than 20 years. We also have Dr. Bill Doherty, a professor in the Department of Family and Social Science and an adjunct professor in the Department of Family Medicine and Community Health at the University of Minnesota, and one of the founders of Baby Boomers for Balanced Healthcare. Dr. McKegney, Dr. Doherty, please take it away.
Hello, everybody. This is Bill Doherty. Happy to be with you for this call. So if we could go to the next slide, our opener here. What we're gonna do is briefly talk about Baby Boomers for Balanced Healthcare that developed this podcast series along with Health Partners Park Nicollet in the Twin Cities in Minnesota, and then we're gonna have a demonstration. We're gonna listen to one of the podcasts. We'll do Q&A, and then we're going to talk about a brand new thing we've developed for a workshop for caregivers who are concerned that somebody in their life is involved in medical overuse. So briefly, Baby Boomers for Balanced Healthcare is a group of citizen baby boomers who believe that healthcare spending is out of control and will bankrupt our country unless we all take responsibility for changing how we do healthcare. So it's this small group that's been together for a few years. We want to stimulate a local and national conversation about changing the cultural belief that more healthcare is better healthcare. And we believe that in today's healthcare system, there are too many tests, procedures, and services that don't help and can harm. We are overdosing on healthcare. These are ideas familiar to everybody on the call. And we sponsor community conversations about medical overuse. And we decided to develop a guide for clinicians on these conversations. We approached the Health Partners Institute to partner on the project and bring the guide to fruition, and it is now at fruition. Some months ago, we did a webinar on clinician-patient conversations where the patient wants more than the clinician thinks is appropriate and useful. And today we're going to be talking about how clinicians can talk to a caregiver. And next slide, please. And so, Cate, this is for you.
Thank you. So our goal was to come up with some practical tools for conversations when, as Bill said, we have a series of these. The rationale for coming up with a guide is that these conversations can be difficult. In general, talking with patients, the patient and family may feel and may be underserved. There can be unproductive disagreement, and there may be third parties, especially other clinicians and family, who don't agree with the amount or the type of medical care diagnostic interventions that are occurring. Clinicians, by and large, have not been trained to handle these kinds of conversations, and the conversations can take time. The inefficiency is more often occurs when they are when you try to skip over them, actually, rather than when you try to work them through. Next slide, please. So our approach has been to develop simulated conversations, which we did extemporaneously rather than doing them scripted, in order to try and capture the glitches and imperfections that happen in real life that don't ever happen in a script. And then we debrief them to begin to get at why and how, what the patient or family member and clinician were thinking that led to whatever statements were made. We've developed a variety of scenarios, and then in which the patient or family makes a request for an unnecessary diagnostic test, a more aggressive treatment plan than it is needed, and then an additional one looking at discussion following a request for long-term opioids for management of acute on chronic pain. One of these scenarios involves a caretaker for an elderly parent in discussion with a clinician. Next slide. So the importance of skills with caregivers is that the conversations are becoming more common as time goes on and as more of us, as the population ages. The dynamics are somewhat different than with talking with an individual patient because the relationships are more complicated and in some ways have more history. Most clinicians are not trained in the modified conversational tools that are needed in this more complex multiple body problem. Next slide. Bill?
Yeah, so some caregiver dynamics that won't be unfamiliar to people on the call. Now, caregivers have a feeling of responsibility for another person, and that is different than for self. And so caregivers can feel more, they can be more reactive because they're taking care of somebody else. With an elderly parent, there is often the switching of roles. Who's taking care of whom? This is the person that raised me. This person took care of me, and now I'm taking care of this person in my life. And of course, there's a long history, and there can be residuals from past sense of how each of them, how the parent parented, how the child was a child. And so lots of history, as Cate said. Third is the caregiver can feel the need to be a champion or watchdog. This relates to the first one. I'm responsible. I got to watch out for mom, dad, and I have to make sure that I can feel like a gladiator against the system for this person. Doing less can feel irresponsible, even if doing less for me might be okay. I can assume the risks of watchful waiting if you've convinced me of that, if you're my clinician, but I might feel irresponsible doing, quote, less if it's taking care of my aging parent or my young child. And finally, there are multiple players or stakeholders in the extended family who are watching and sometimes judging. So if I'm the principal caregiver, I'm going home and I'm going to have to report back on our conversation. And if I have allowed you to, convince me to do less than what others in the family might think is appropriate, I have to defend it to them. And so I may be more difficult in the clinical encounter because I don't want to have to explain this when I go home. Next slide, please, and then Cate.
Mm-hmm. So our approach with each scenario has been to basically make podcasts of 4 different conversations. One is a routine conversation of how things often go in a regular practice. And then 3 more skilled conversations. One simple conversation where the suggestion of change is fairly straightforward to make and accepted by patient family without much dancing. A more complicated conversation, whereas Bill usually puts it, the still waters have gotten a little bit more complex, a little rougher, and the clinician needs to attend to a little bit more to the motivations and concerns of the patient or family member. And then a polarized conversation where the patient or family member remains relatively unconvinced and is still not happy with the idea of doing less. The skill we realized that particularly came up in the polarized conversation is the skill of ending a conversation that's polarized without reverting to angry words and with maintaining grace and integrity, or at least integrity, so that the clinician doesn't end up doing or saying things contrary to values. Leaving the relationship open even when the conversation is ended. After each one, we taped a debrief where Bill asks questions and talks about how he felt as the patient caregiver, reflecting on choices made about differences in tone, style, language, and as the slide says, both the clinicians and the patient's experiences. Next slide. So this particular demonstration conversation, the scenario is that an elderly patient's caregiver, her son, calls a physician asking for urine analysis and culture for his confused mother on the assumption that she might have a urinary tract infection. She's been confused for a while, and that in the past this worked because she often had bacteria in her urine, was treated with an antibiotic, and got better. So we did the 4 conversations for this scenario, and this particular segment represents the complicated conversation. In the podcast, it follows a simpler conversation in which the physician explained the rationale for not doing the urine screen, and the patient accepted that decision with reassurance and some explicit instructions about what to follow up about if needed. The complicated conversation starts with, instead of agreeing, the patient's caregiver pushes back instead of going along with the recommended plan.
And so, Cate, if I could add something here just for listeners, that we're assuming here that you as the physician have done an adequate workup, and and that you kind of know what's going on here. It's not that a cold call comes and you say no to to the urine test, but haven't done an adequate workup. So just to reassure people of that.
Right. And this is where we would play the podcast.
So, Doctor, what's the harm? What's really the harm in doing the culture and maybe trying an antibiotic? I mean, it's worked in the past. What's the harm? It's not very expensive. We know she handles antibiotics, so what's the harm?
Well, what kinds of things have you heard about the pros and cons of antibiotics in general?
Well, I know that usually in 10 days, if there's an infection, they usually take it away. And, I know they don't treat viral illnesses like colds and so on, but this may be a bacteria in your urine. And, and I've heard and read that sometimes too much antibiotics can make people prone to infections that antibiotics can't handle. So I know there's a downside to it.
So the overuse of antibiotics has caused a lot of problems for the world and also for some individuals. And that's one of my concerns about starting down a path that leads us to antibiotics when I don't think they're likely to be helpful. The superbugs that you may have heard about in the newspapers only develop in the presence of antibiotics. And I don't want your mother to develop any of those. I mean, we all have germs in our bodies that are capable of becoming those if we give them too many antibiotics to learn from. And the other is that using antibiotics can kill off the good bacteria that actually help keep us healthy, particularly in our intestines. And I also don't want your mother to run into trouble with that. So antibiotics are powerful tools and can be powerfully dangerous, particularly in the elderly.
So what are we going to do then?
Well, I want your mom to get better, and I want her to be safe. And so what I think we should do is plan on using antibiotics when we're sure that there's an infection that she needs them for, so that they will still be effective. And when it's worth the risk of killing off the good gut bacteria that her body relies on for certain vitamins and functions. I think that this is not a urinary tract infection, and we obviously need to keep an eye on her because she's feeling punky for some reason. And if she develops any of the symptoms that look like urinary tract infection, I expect to hear from you. And if she's not better or getting closer to her normal self in probably 48 hours, or if she gets worse before that, I want to hear from you again.
Okay. Yeah. Okay. Makes sense. So let's talk about how this conversation went. So a little more turbulence here. I started off saying, well, what's the downside here? Okay. I mean, it's taken all these before. It's not that expensive. She handles antibiotics well. You've heard that before. And so you chose to begin with a question to me rather than a spiel. And why did you choose to start with a question?
Because if I start off by the spiel, then I'm sort of telling you you're wrong or arguing with you. And I suspect that you heard about the risks of overuse of antibiotics. And if you produce that information, then you can be right, and I can help you with being right. And, you know, as a caregiver, you want to do the right thing.
Yeah, if you had just begun with what we're calling your spiel, it would have come across as a yes, but. You know, I'm saying, well, it's help before and blah, 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 and you would have been countering that, but they're dangerous. Okay. Then I might have said, well, how dangerous are they, kind of thing. So you asked me, what do I know? And of course, I first said how helpful I think they can be. Now, suppose I had stopped there. Suppose I had said, okay, you know, I think they can be, you know, they really help people, you know, 7 to 10 days, not that expensive. Mom handles it well. So now maybe in the back of my mind, I know, you know, that they can be super bugs on. But suppose I didn't give you that. What would you have said next?
What else have you heard?
Okay. And would you flat out ask if I'd heard if they can be also
I would
dangerous?
probably try, what else have you heard? And then if you said, well, I don't know, nothing else, I would say, have you heard about any downsides?
Yeah, okay, right. Because what I was aware of in our little demo, I was sort of handing you that. You know, I was being, you know, I was being helpful here. But I was curious about, you would have tried to elicit that from me.
I would have given at least one more shot.
Right, and then, and most people probably have heard, and if I hadn't, then you would have said, well, so, you know, I have some information to fill in. Okay. So then we went through, and I pushed back a little bit more. I'm really worried about her. And then I found, and I'm interested in your commentary, I found you going even more towards me about, we got to follow up here if this doesn't clear up. Okay. Even more than in the first round. Okay. So tell me what went into your response to me.
Well, when you said, I want this quick fix because that's how I want to take care of my mom, then I basically upped the I'm worried too. I'm with you with being worried. And these are got more specific and emphatic about that I'm going to help take care of her. So that, because I didn't want you to feel that you were in opposition to me as the one pulling for more care and me saying no less, I'm saying no different.
Yeah, you also said more definitively you do not think she has a urinary tract infection.
Right now I don't.
Right. And so that was, that's your medical opinion there. You said it pretty clearly. And then you said, however, I'm worried and concerned, and you, as the caregiver, you were with me there in my concerns. I'm repeating what you just said. And you said, I expect you to get back to me in the next couple of days if nothing's better. So you weren't just withholding something, right? You were connecting with my concern, and we were on the same team in wanting to understand this. But you were saying at this point, I'm ruling out for now this particular path. But the other
So you don't call me just because you're more worried.
Right.
I want you to call me because of the specific things that I would be worried about.
Yeah, and for me, it left me as the caregiver with something to do, something to think about, not just I went to the doctor and we didn't get anything. Okay, this was
Okay, are we back?
We are back.
Okay, so this would be a time for people to ask questions, make observations, and they can do that, I understand, through the chat room. Can people also unmute themselves? So remind us how we do this.
Yes, so if the attendees have any questions, please feel free to type it on the chat box, and also if they wish to speak, please feel free to click the hand button to raise the hand and you'll be unmuted.
Okay. So as people are thinking about questions or comments, and Cate, I just thought I'd kick it off by saying, as I was listening, I was thinking about the last of those family dynamic issues we mentioned, and that there's other stakeholders out there, and the fact that you were emphatic about following up would help me with my siblings who are also concerned and who are maybe expecting that there's going to be an antibiotic coming. And that I can say to them, well, the doctor told me, get back, promptly if these things are going on. So I was just aware, and I want to know if you want to comment on that, because that helps me with those others out there who you're not actually talking to, but I'm going to have to talk to. So any reflections on that, Cate?
Well, sometimes not so much in this context, but in other contexts where I'm aware that there's someone that you're reporting back to, or someone who's emotionally or psychologically in the room, but not physically in the room, is to offer to talk with both people at once, if that would be helpful. And I acknowledge that in the many times I've made that offer, I can count on one hand the number of times somebody's actually taken me up on it, but they seem to relax when I make the offer. I don't usually offer to talk to each member individually, because you can end up, it just gets more confusing because people misunderstand or understand what I've said differently. But if we're all in the same conversation, then there's a little less, well, she said this, no, she said that. Does that make sense?
Sure. Now, in this conversation that we were doing, what might I have said that could trigger you to say, would you like to have a phone call with so-and-so, or I'm just thinking out loud that maybe if I had referred to a family member, like maybe my sister is a nurse, right? And she really thinks that mom needs it. Is that the kind of thing that might trigger that invitation?
Yes. Yeah. And I would say something like, it sounds like you're under a lot of pressure. If it would be helpful, we could figure out a way to do a conference call with you and your sister at the same time. Yeah.
And so there are two parts of that. You said to me, you acknowledged the pressure I feel, right? So this is, that helps me. This is not just information sharing here. This is like, if I bring up a relative who really thinks something should be done, and I'm agreeing with you not to do it, then I'm under pressure. So it was empathy for me in my situation and offer of something specific.
And offer to do the whole system, but not to do it piecemeal.
Okay. So folks out there, yeah.
I do have a few questions, and the first one was, are you including advanced directive care planning in these discussions or samples?
The short answer is no. We're dealing with these 4 scenarios where there is a difference of opinion between the patient or caregiver and the clinician about a test or a medication, or so. But we're not. It's a great idea, but we're not doing those here.
And some of our decision making about that was that there were other people working on that back when we were deciding which scenarios and which conversations to work on.
And another question we have is, have you created scenarios from the perspective of the patient or caregiver? Can they just reverse the roles and share their observations and concerns, and medical provider will assess and enter into the exchange?
Gee, I don't know if I understand the question. Do you, Cate?
No. When we develop the scenarios, the majority of the folks in the room, when we develop the scenarios, are not clinicians. So I'm not sure what the question actually is.
Yeah, so just to be clear, what we did, we wanted to, this is a training for clinicians on how to talk with patients and caregivers about medical overuse when there's a difference of opinion. So that's what we're doing. And what later on in the call, I'm going to talk about some additional work about how to help caregivers and loved ones intervene when they are concerned about something. But anyway, that's so to the extent to which we understand the question, the answer is no, we have not done that.
Those are the only 2 questions I have so far.
Okay.
I have a question. So one of the things I love most about the podcasts is where you unpack all of the feelings from both the patient and the physician. And I see definitely the value in modeling the conversation. But when you unpack it, are you also trying to model how clinicians can think about their conversations? Was that your intent?
Yes, for sure. Yes, for sure. Because otherwise, simply a demonstration of a set of skills, I think, is not deep enough, because there are all these choice points involved. So yes, so definitely. And Cate, you want to follow up on that?
Well, and a lot in several of the debriefing, the unpacking sections of the podcast, Bill asks me why and what he did that cued me to do something. And through that conversation, we came to realize that there were some underlying guidelines that I tend to use that, like if I'm talking a whole lot, then I'm not asked that's a cue to myself that I'm not asking enough questions, because people's, at least when I've given lectures, people's eyes tend to sort of glaze over. Well, it happens in the exam room too. But what that little bit of memory, if you're talking too much McKegney, then you have to ask another question, is a cue to myself about moving it around to being more patient or caregiver centered on this caregiver and this patient, because they're the experts in what this situation is. I'm only the expert in the science.
Yeah, so I think of these conversations as mini dances, and you can, as a clinician, you can probably only script out the first move or two, maybe just the first one, and then after that, it's going with the flow of how the conversation goes. So the unpacking allows us to get into the choice points, and then I, as playing the patient here, can talk about what they meant to me. So just as Cate and I were doing a little example of that after the podcast was finished, when I was saying what would have cued you to invite a conversation with another relative, when she said, not just, yes, I'm happy to do that, or why don't we get your sister on the phone too? She said, yeah, I realize you're under pressure here. That was a beautiful thing to say, and somebody just listening to a podcast might say, well, okay, well, that was obvious, but no, that's not obvious. Mm-hmm. It's not obvious to first connect with not only the emotions, but the position of this caregiver in the family system. That was a pretty powerful piece of empathy for me, not just, gee, you're feeling concerned, Bill, that's sort of basic empathy, but Bill, you're in this, you're the point person and under pressure. Mm-hmm. That goes a long way in a relationship with a caregiver. And what I'm saying is, and to follow up to your question, Kelly, that can only come out in a conversation about what happened. That's not going to come out in just the demonstration of the skill.
Hi. We have one comment here that we just received, and it says that I have found that documenting salient features of the discussion in the patient instructions and printing that for the patient family to take home is helpful, is that it's written evidence of the discussion rather than the family member being pressured to relay what is recalled. Keeping those documented details in the same vein as the team approach that the conversation had can be very helpful for the other family members to read. Mm-hmm. Good point.
Mm-hmm. Mm-hmm. That's a great point. As we all know how much people forget by the time they leave. So I think that in addition to the conversation, whatever documentation is a great point. So I wonder if Kelly and Tanya, this might be a good time to move on to the next part of what we're doing.
Just before we move on to it, I just want to cue the audience to the handouts. The health partners were a great help on this, and you can go to their site and get all of the podcasts and learn a little bit more about the project from their site on the Health Institute website. But yes, after that, I do think.
Yeah. So this is the slide we're looking at now, and when we maybe when we're sort of Balanced Healthcare approached health partners. And Park Nicollet, the two partners that came together, we were really interested in this being something for, of course, the professional development of clinicians in health partners, but also something that could be helpful nationally. So that's been the idea from the beginning. And again, we have 4 scenarios and then 3 conversations for each of them. So there's 12 in there: simple, complicated, and polarized, and then commentaries on each of them. So we want to encourage folks to access these, and these have been vetted and piloted and worked on within health partners before we were all ready to make these national. And now what I want to do is to just give you something, some ideas from Baby Boomers for Balanced Healthcare for caregivers and loved ones. So if we go to the next slide. So we've developed a workshop, and I want to say we're going to be, we have not done the workshop yet, okay? So this is something we plan to do, but we thought while we have you on the call, and since this was about caregivers, it might be interesting to tell you about it. And I'll be fairly brief. So here's the description of the workshop. Sometimes we worry that a family member or close friend is overdoing their healthcare, taking too much medicine like pain pills, seeing too many doctors without enough coordination, or receiving tests or treatments that experts now think are of questionable value. These are delicate situations. This workshop will give you tools for raising concerns to family and friends about possible medical overuse without giving offense or hurting the relationship. You will learn how to bring up the topic and express your worry in a caring, diplomatic way, rather than staying silent or coming across like a busybody or an expert. And we'll have a good time learning skills that may help in other family situations too. So that's what we've been inviting people to do. And I'm going to give you a little piece of the curriculum for this workshop, if we could have the next slide. So we have 5 strategies, and we figured out a way to make them all C's. Clarify, tell a counter story, concern, express concern, show compassion, and offer choices. So clarify, counter story, concern, compassion, choices. So by clarify, we mean ask calm, non-challenging questions about the medical plan and the rationale for it. And again, keep in mind, this is a loved one who, maybe keeps getting opioid prescriptions, right? And I'm hearing about opioids. I wonder what the heck's going on. Or the surgery seems like coming up so really quick to me. So here's an example of what we call sample line of communication. Did the doctor say why he or she wants you to do surgery instead of physical therapy? So that's asking a clarifying question. Second, tell a counter story based on your experience or that of someone you know, but don't assume it's the identical situation. My friend's doctor said he preferred to postpone back surgery and see if things get better with time. I don't know, maybe your situation is different. So can you see that's bringing up a counter story, but then with the I don't know, maybe your situation is different, not putting your friend or loved one into the position of just, having to feel like they're being told your doctor made a mistake. Third one is express concern, and this would be maybe if you're still concerned after the first 2 conversations, directly say that you're concerned that there may be too much testing or treatment going on. It can be helpful to first ask permission to offer a challenge. For example, is it okay if I bring up something I'm concerned about? If you get a green light, then express your concern. And again, a sample line of communication here. Ever since you told me about getting those narcotics for your headaches, I've been worried that they won't be good for you long term. And so teaching the skills of directly raising a concern. So if you only stick with clarifying questions, or you keep telling counter stories, then the person knows there's something on your mind. There's something you're concerned about. And so a communications tool that can be useful is to ask permission, to signal that you have something on your mind. And then notice the skill here is an I message. I've been worried, I've been concerned. If you express a concern that doesn't have an I message in there, you can come across like you're the know-it-all. You know, those narcotics, people are using those too much and blah, blah, blah. And whereas if you say, I'm worried that they won't be good for you, you know, this is personal. So a family member, loved one, probably is best not making dogmatic sounding statements about what they heard on public radio or read in the newspaper, but expressing their worry or concern. So next slide. And so the fourth is compassion. If the loved one seems embarrassed about the overuse, emphasize that it's easy to get swept along once the medical system gets in gear. So this is when they're saying, yeah, I don't know if I ever should have started down that path. It's not your fault. I would probably not have objected in the middle of the night when they put mom on the ventilator. So now we're talking about, of course, an end-of-life situation. Some big deal, and one of the, maybe the main caregiver gave the go-ahead, and maybe there was a, there's end-of-life planning that had not considered that, maybe, whatever, but okay, on the spot, I did it, I feel bad about it, and so you can express compassion. And then the fifth one, it's all for choices. If the person seems open to your input, then here are some possibilities. And so we got 4 of them. I suggest slowing down the decision-making process if it's not an emergency. We don't have to decide today. Let's take some time to make sure we're doing the right thing. Again, that might be, some of these end-of-life situations where, you're not in an emergency. You can slow down. Suggest getting other professional input. This is a complicated decision. I feel better if we get input from another medical team. Next one would be recommending widening the circle of loved ones involved in the decision. I feel better about this decision if we talk to more family members and see what they think. And the last one is offering references such as Choosing Wisely and other sources on overuse. Would you be interested in looking at some of the things I've read about this in sources that I think are trustworthy? So what we're talking about here is being a consultant in one's own circle, one's own family, friends, loved ones, when you're concerned that they may be involved in an overuse situation. And these are some of the skills that are involved in this, that come out of this, so developed by the Baby Boomers group, and kind of with a filter of some of what I've learned as a family therapist about how to have conversations with loved ones in a way that doesn't just get them reactive, just doesn't push their buttons. So with Health Partners, now that we've launched the podcast series, we are interested in doing more community conversations. Baby Boomers developed a conversational process about overuse, where people get a chance to talk about the issue, the sources of overuse, how it's come up in their life, what they've learned personally. And then this is another one we want to try out to help loved ones with the skills of how to bring up these kind of delicate issues. And I just gave you a little sample of it here. We've got other parts of this that are about ways not to come across like you're the competing doctor or clinician, how not to undermine, never just directly, undermine the provider. So we've got various kind of warnings as well. So I think that was our last content slide. Can we see the next one? Maybe it's just, there we go. So questions and discussion. So we have, 5 minutes or so for questions or comments about this last part, about the content of it or about the use of it, that we'd be happy to entertain. And as people are doing that, Cate, if you had any reflections just as you listen to this again, we haven't gone over this for a while, just anything that you think of as you listened.
Well, as I've been saying since we started the Baby Boomers for Balanced Healthcare work several years ago, my goal in doing this is is that when I'm talking to a family, I'm not the first person who's mentioned balancing risks and benefits in doing things to old people. So this is yet, I think, a possibly very fruitful way of beginning to grow medical experts in families, because there's always at least one who have that concept and within family discussions, so that Dr. McKegney is not the first weirdo asking this stuff, the first person bringing up the concept that overuse can be harmful to people.
Mm-hmm. Mm-hmm.
And I have one comment here, and it says, the comment is, I like the method of engaging the patient family in a way to keep it as a team effort rather than an antagonistic discussion arguing about the situation. That's a good comment.
Mm-hmm. Mm-hmm.
Yeah, you have to start off by asking questions of folks. If you start off by lecturing them, you've lost the engagement.
I have a question. You know, we're big supporters of the overuse conversation model that you've created. But one of the things that we've been talking to patients in focus groups a lot is the difficulty with misinformation. And I liked, obviously, that you said choosing wisely materials, but other trusted materials. Does the workshop deal with any of the difficulty with navigating what sources are reliable and which sources are not?
No, but I think that's a great idea. Because you're right, it's the Wild West out there.
Right.
And this is, and then in different family members access different sources. And so I think that's a really good idea. Yeah, we kind of snuck that in there, you know, choosing one other trusted sources. There's a big question mark about what those trusted sources are.
And one of the things that even before the invention of the internet, people would say, I heard about, and I always, before I could comment, said, I really need to see what it is that you're talking about, because there's so much stuff out there, I haven't read it all. And so I don't know which, I needed to know which study, if it was a study, in order to be able to interpret it accurately or understand the interpretation that family was putting on it.
Well, the other thing I'd like to say from again, the family perspective is that a lot of times what family members are advocating for, it was conventional medical wisdom 20 or 30 years ago. Mm-hmm. And having that in mind is really important for the clinician, not to come across, you know, the grandma or your sister who is a nurse or whatever is somehow a doofus, because often these are exactly what patients were advised to do by card-carrying clinicians in the recent past.
Very recent. My biochemistry professor in medical school used a term which I have used probably every week ever since, which is current truth is. And I actually have some rather extended stories, which I will not burden you with, of how current truth has flip-flopped back and forth about a number of treatments for a number of very common illnesses like congestive heart failure over the course of my admittedly long career. And so oftentimes when families would say, well, so-and-so says I should do this, I almost never say, well, they're wrong. I almost always say, there was a time when we did that. And now we have more recent information and do things differently. And there are some treatments that I start and say, you know, before you change this, you know, like a device that only supposed to last 5 years, you know, check in because we may have more updated information that it will last longer. Basically emphasizing that one of the characteristics of scientific medicine is that it is always changing because we keep trying to do better.
Mm-hmm.
Well, and I think I'd add to that in terms of the choosing wisely approach is that so often that has been the new is going to be more.
Mm-hmm.
And here we're talking about situations like we just enacted now, that the new is less. And that's a culture shift. That's a culture shift. So that's some of what we're all involved with here. And a key thing that comes across in these podcasts and in our workshops is that we're in this together. There's no, you know, and that we have to be on the same side here in promoting good health for everybody, as opposed to, and avoiding as much as possible being antagonists. And there are skills involved in getting on the side of the patient and family when you start out with disagreement. So if I have to summarize that, when you're starting out with disagreement, how do you get on the same side? And that's what we're trying to demonstrate how to do here. So it looks like we're at the time we should be closing up, Kelly?
Yes. Thank you so much for your great conversation and the tools that you've provided. I do want to say to the participants, if you're interested in learning more about choosing wisely, feel free to reach out to me. And there is an opportunity if you'd like to learn more about the workshop series. When you fill out your evaluations, you can share your email with us and we will get back to you. So thank you. And Tanya, Marilyn?
Okay. Thank you very much, and please feel free to contact us if you have any questions that we can help with.
Yeah, and please take the post-webinar survey. Your feedback will be greatly appreciated, and we will send you the recording within the 24 hours. And again, thank you, and everyone have a good day.
Thanks.
Bye-bye, everybody.
Bye-bye.